back, everybody. Welcome to the Chiropractic podcast for students, by students. We are here. We are the Just Perspective. We are back by popular demand, quickly becoming the #1 chiropractic podcast in the Port Orange area, and by chance, the only chiropractic podcast in the Port Orange area. But we have a really awesome episode planned for you guys. It's been a little bit since we released one, but we have one that is chock full of information, and we're going to do a demonstration. So we have a little bit of a different setup this week compared to the last couple weeks. We're usually around the kitchen counter, but we thought this would be a little bit more functional. And then we have access to the table right there, so you guys are going to get to see that. And just another disclaimer, we are not associated with Palmer College Chiropractic. All of our views are our own. We are not medical professionals, so please do not necessarily take the advice that we give you, but we are here to make your chiropractic experience better. As students, whether you're deciding on going to chiropractic school, whether you're in chiropractic school, or whether you just don't know anything about chiropractic, we are hoping to answer a lot of those questions. So like, comment, and subscribe on our Instagram and YouTube accounts, and we're going to get into it. But guys, it was an extremely busy week of people picking or smacking around the lowest hanging fruit in chiropractic across social media platforms like TikTok and Instagram. I think we have to start warning people that you got to get your histamine vaccine in case it shows up in an x-ray or something along those lines. But a really busy week, a lot of misinformation being spread about chiropractic, and along with some other things in general that have been going around. But overall, we want to make sure that we're bringing to you guys what chiropractic truly is, and we want to be a source that's accurate, and then we can go ahead and talk about that. One of the things that has kind of been going on around school is with the different clubs, whether it be Motion Palpation Club, Diagnostic Club, KTC, along with a lot of other clubs, going over the SI joint and how to palpate that, and then finally how to adjust it.
What?
You want to riff a little bit? Talk about chiropractic?
We can riff a little bit. I mean, look.
Okay, real quick, couple minutes. So this guy, give everyone a little bit of an update about what's kind of been going on around school, some of the things that you guys have been learning about, and then we can move forward.
Yeah, before we started this, the first episode that we filmed, we were all still on the only academic side, dealing with only students. But since most of us have moved on to the clinic, and that's been a crazy change of going from just being in class every day. And we still have a lot of in-class hours, but our lives have changed dramatically, at least on the academic perspective, because now we're working with real humans, and we're in the clinic, and we get to see what it looks like to treat patients as our own, right? Prior, whenever you're in the school's program, and we have what we call TOL, right? That's student practice time. Everybody's getting adjusted by everybody. All the students are all very healthy and have minimal problems. The practice, and it's just for practice, right? Like you can't really prescribe like an exercise program or like see the progress that your patient is making. So one of the things that's really been a huge change, at least for me, is having patients that I'm taking care of. Right, having patients that are seeing me on a regular basis and are listening to the stuff that I'm telling them to do, and most importantly, are getting results. Right, and also like in the clinic, we have a little bit more freedom with the things that we can do as far as creating like complete and total care plans. So that's been a huge change for at least for me. Getting hands on and being able to treat people has been an incredible privilege. That going into it, I definitely was a little bit scared. Right, not scared, but I guess maybe overwhelmed, right? Because that's the moment that we're looking for, like as students, like we're all waiting for it, and finally getting there.
I was scribing for Eddie's patients the other day, and I was kind of scared. Like I was there just typing. I'm like, oh, dude, bro, they're not young.
Yeah, I got my first outpatients, and obviously HIPAA, not going to say much about them, but they were a little bit progressed in age, and I wondered like how would I be able to adapt, and it was cool because I got to use a couple of different techniques, and I got to use Thompson drops and activator and kind of switch it up a little bit compared to what I regularly would do. But that's just been the biggest change in our lives so far, is that we're actually treating patients, and we're actually like being helpful and being of use to people, and it's been an incredible blessing for me. I don't know how you guys would feel like would say about your clinic experience so far, but I would say that it's been an incredible blessing and a privilege to be able to help people, and has changed my perspective on how to approach patients a lot.
Yeah, Joe's been prescribed medication in his mod, so they go.
Yeah, just like behind the clinic, behind the dumpster, you can meet me and get maybe some supplements or something. Some special supplements. No, but
before anybody clips this and says chiropractic students are wax, this is entirely.
That's a riff. It's a riff. Everybody relax.
For legal reasons, we are joking.
Yeah, we don't do that.
What are you saying, Joe?
No, but in all seriousness, like one thing that's been really cool about going into the clinic is like you learn all this like basic science and then like the past like NMS and passive care and active care and all that stuff, and like you just kind of learn the random facts and like it doesn't really make sense to you and like in your brain at the time. But then like you have a patient in front of you and you're like, oh, like I actually know what to do here. Like when like you didn't really like you weren't really sure that you would know how to do that, but then like you get the patient in front of you and you can just kind of put the pieces together that you learned in the previous tries and just use those pieces to help get someone back into like good health.
Yeah, I think I feel like, I mean, I'm sure you guys have heard me say this when I've been here at school. I think every student says it at some point in their academic life. It's like you go through like undergrad, especially high school, all those years, you know, it's constant like, when am I ever going to use this? Oh, I don't need to know calculus. You know, when am I ever going to use this? And like what you were saying, it's like it's nice to finally like we've learned something and now we are actually applying it. We're no longer just, I mean, though we're still in classes and we are still students, it's nice to be in that clinical setting. And though we are treating patients, like technically the doc that we are working under, our mod doc, is the one treating the patient.
And he signs off on everything.
Yeah, we get to be hands-on. We get to, like, for instance, in my mod, I'm with Dr. LaCourte. You know, I go in and I get to like kind of assess the patient and I kind of give him a rundown of it. And it's kind of cool to like balance ideas off each other because I'm learning the whole time.
Yep.
I'm getting that experience of like, instead of like, I know Carson, I talked with you about this the other day, like instead of just going down that single lane road where it's like someone tells me like, oh, I've had this pain going down my leg. I'm like, that's sciatica. It's now I'm like, okay, this could be sciatica. This could be a disc herniation, you know, et cetera. Like it could be anything. But it's cool that that all stems from like what we actually learned in school versus, you know, when you're in undergrad learning, like taking all these basic sciences your freshman year and you're like, you know, will I ever use these in my profession that I want to do? Like we're actually there now. And we're so close to being like out on our own, which is even more scary. But it is a nice thing that we finally get to experience.
Yeah, I'm scared. Joe had a strategy for before we get to preceptorship. Joe, what was your strategy? No, just kidding. No, just kidding. Yeah, but it's everything's been fantastic. Moving into the clinic setting, and then moving forward with our chiropractic journey. Again, we do a lot of academics here. In the first 2 years of chiropractic school, for all those you are wondering, you're sitting in the classroom preparing for that Part 1 board, and then as soon as you graduate from that section of chiropractic school or that time period, you move into the clinic setting for your last year. Again, we're going to school all year round. It's not just 2 semesters, but you're doing 3 trimesters, and then we're finally in the clinic, so that's great. And then just another update of some things going on around school. We have some students starting us some new research projects, working with Dr. Merkus, which is really cool. Just some literature reviews and one meta-analysis in the work. And then we also are doing a new dissection in the lab. We're talking about doing a spinal cord dissection, which is really, really great. As chiropractic students, really important to see some of those structures as they're running out of the spinal cord through the IVF, do some laminectomies in there, and then how like that feeds into the sciatic nerve, running out the posterior aspect of the sacrum and the lumbar spine running into the leg. And that's a really great segue for what we are going to be talking about today, which is the SI joint, the anatomy, as well as side posture adjustments, so you guys are in the right place if you're wondering how to palpate and then adjust the SI joint. But let's get into it. Eddie is going to start us off with some of the anatomy for the SI joint.
Well, the SI joint, otherwise known as the innominate bone, it's a. Can you pass me the spine real quick? Since I guess that we got it out here, might as well talk about it. It's when we reference the SI joint, right? We're talking about the articulation in between the sacrum and the ilium. Now, the ilium is one of the 3 bones that make up the innominate bone, which you have the ilium, you have the ischium, and you have the pubis bone, which have all fused, obviously, like in I guess in the womb and in early moments of human development. These are all 3 separate bones that then fuse to become one solid bone. But this is one of the most important structures that we're going to talk about in chiropractic because this is the base, right? This is the foundation in which the rest of the spine is sitting upon, and then all of the weight bearing is done by mainly L5, but also the L5-S1 articulation, which then that's the pelvis, right? And I would even argue that L5 is a part of the pelvis due to the iliolumbar ligament that connects it to the actual ilium. But there's, for some reason, like I've seen in the webs and the social media, that the SI joint has become a rather hot topic, a topic of debate. And some people will even say that there is no movement in the SI joint, or that it is a functionally fused articulation. But In just about all of the sources that I can find that are most up to date, you can see that there is at least the 1 to 4 degrees of movement in the SI joint. And obviously, when we're talking like of degrees, like it's not 100, it's very little, but that little bit of motion allows us to move and is biomechanically very significant, right? The other thing is, you got to think about it biomechanically. When you're walking, right, like one of these is always going to be weight bearing, and the other one is going to be an open chain movement. So they're going to move away from each other in different ways. But you know that's the basic anatomy of it when it comes to bony structures, right? You have your sacrum, right, which also like in development was multiple segments and then fused into one, and then you have your 2 innominate bones, and that's what makes up the structure that we like to call the pelvis, right? When it comes to musculature, right, you have all of your hip flexors, extensors, hip internal rotators, external rotators, but you have 2 basic motions that happen at the SI joint, and I would call them nutation and counternutation, and then circumduction. There's different names, there's different like words that people use to describe these movements, but when we are referencing nutation, then you can fact check me on this. That's when we're talking about when the ilium rocks in either direction, the sacrum is going to move opposite to it, because a lot of the times we see that the pelvis, that the ilium and the sacrum will move opposite to each other. So if I'm not mistaken, nutation would be extension of the SI joint upwards. So when the ilium rocks forward in flexion, right, the sacrum is going to rock in the opposite direction. And that's what we call nutation of the entire structure. And then same thing backwards, right? When the ilium rocks back, the sacrum is going to rock forward. So that's that nutation, counternutation, because even though, you know, like they're separate bones, movement in the ilium affects the sacrum, right? That's why it's an SI joint, it's a synovial joint, so there is obviously some movement. And we're talking about circumduction, right? That's that leg fanning, and we have even less movement in degrees in that position, but due to the ability to internally and externally rotate our hips, at the end range of that femoral movement, you're going to see that the ilium is going to move inwards on the sacrum or outwards on the sacrum, depending on whether it's internal or external rotation. So even though a lot of people believe that this is, and through early literature, and the older you go back, a lot of people believe that this was a functionally fused or even an actually fused segment. There is a lot of biomechanics that go into this, and it's a very important area to be able to assess before you get to adjusting people. Because if you keep addressing the lumbars or the thoracics and you've never given attention to the pelvis and what's going on here, you can create a lot of problems down the line. And then I mean, I think that's all that I have to say about that.
And one thing that's really important to remember, because it kind of gets lost when everyone's learning about kinesiology, it's really easy to, when you're learning about the pelvis, to picture the movement of the pelvis being very drastically different when we're talking about coupled motion. So I remember when we were in movement science, there was that one question where when you're assessing the patient functionally, they're sitting on a chair and they stand up. What happens to the pelvis in the first 45 degrees of the person, or the first 90 degrees of the person getting up off the chair? And I remember we were sitting out in the hallway afterwards, we were all arguing about it. Like, no, it goes into nutation, it goes into counter-nutation. And I think the thing that really messes with people, especially with how we look at it as chiropractors, is we want to think about, like, when the sacrum goes into nutation, the front part of the ilium is going to rock like anterior and be this completely like opposite movement. When in reality, like when we're in nutation, you're just getting the slight rocking of the ilium. So then when you're assessing it, you're not necessarily doing palpation in a way that you're going to see like 45 or 5, 10, 15, 20 degrees of that range of motion difference when you're evaluating it. And for all of those of you who don't know, maybe you're coming into chiropractic school, some of the more popular ways that chiropractors have tried to evaluate the ilium and the sacrum is something called line drawing through x-ray. When you guys look up on the chart that I have up on the screen, the largest degree in terms of millimeters that's measured, obviously it's a very controversial topic. It goes anywhere from 0 to 8 millimeters, 1 to 9 degrees. If a person is having some kind of movement issue, maybe something is torn, maybe there's a little bit more movement that was put into the ilium and the sacrum in general, that maybe it would move up towards 8 or 9 degrees. It's extremely minimal, the difference that you would see maybe if you were to do some kind of like line drawing with an x-ray, but overall you're looking for the movement, the small amounts of movement that are in the sacrum and how it's approximating with the ilium. So it's not necessarily like this broad difference of movement, but overall just very, very subtle amounts. We have to think about the synovial joint that is the sacroiliac joint in the middle there, and then you have to think about the other structures that it's connected to with the femur, because you have one of the most mobile joints in the body, which is the acetabulum, which is the femur on the ilium and the ischium, but then you also have the sacrum moving on the ilium. If there's something wrong at the head of the femur, maybe there's an impingement syndrome, or if there's something going on in the lower back, the rest of the body in that area is going to compensate to limit movement and then cause hypermobility somewhere else. One of the things that Eddie didn't necessarily talk about when he was talking about the anatomy there are the 4 posterior ligaments that make up the big ligamentous structure, which is something that we focus on as chiropractors, and then when we adjust and when we manipulate. So you have the sacrotuberous, sacrospinous, iliolumbar, and then sacroiliac, or the iliosacral. Those 4 ligaments are going to control, at the very least, the structure and stability of the SI joint at the smallest, most minimal level, right? Muscles are going to move bones, but then those ligaments are going to offer a decent amount of the stability of the joint there. Does anybody have anything else to add? Something that they've kind of learned about the ilium?
Yeah, I was just going to say, kind of touch on what you had to say. Even though, kind of like Eddie said, the SI joint, it only has a couple of degrees of motion, like 4 or something like that, I think is what a lot of the reference texts say. That 4 degrees is super important. Kind of like what CJ said. If you don't have any motion there, it's going to put stress on the other structures around it. So the lumbar spine above it becomes a little more hypermobile. The femoral acetabular joint becomes a little more hypermobile, and like even the knee joint can be affected. So a lot of times, if that SI joint is chronically stuck or even fused, like from a surgery or something like that, it can create problems down the line, like the lumbar spine or the knee joint, which is a lot of underlooked. So it just kind of, the SI joint can be an underlooked area with those kind of problems.
Yeah, for sure. Because and just so you guys know, whenever we talk about any kind of reference text, you guys will be able to see all of those in the show notes. We will link them so that if you guys want to read up on some of the research that we're looking at as well, you'll be able to. But to go along with that, I'm pretty sure the number is, and like I said, we'll put the reference up there for you guys, is about 15 to 30% of low back pain stems from the SI joint.
100%. Yeah.
So, I mean, I don't know, like what you guys learned in statistics in high school. Maybe this is what I'm actually using stuff that I learned that I said I would never use. But 15 to 30% of low back pain cases, like that is pretty statistically significant in my opinion. So, for some people to like look over the SI joint as a problem area, I would say that is a bigger problem because, like you were saying, if you're having an issue there, it can affect everything above it. So I just wanted to like touch that in there because we hadn't really mentioned any of that. And then I know you mentioned that some people think that it is a movable joint, whereas some people don't. And you talked about kind of the anatomy of that, where like I just kind of wanted to touch on that where. I believe that's kind of because like the anterior portion of the joint is like considered like synovial in nature. It has synovial fluid, while the posterior portion of the SI joint is very ligamentous and fibrous. So it's like the sides of the joint themselves are differing. But I mean, anything you read nowadays is going to tell you that you have about 1 to 4 degrees of motion. So I think that's a very
meanwhile, like status quo 30, 40 years ago was that there was no movement. So I mean, the more that we're learning, the more that we're figuring out.
Yeah.
And I really like how you brought up like how dysfunction at the SI joint can change and can create problems down the line. And it's whatever that percent was of low back pain, and the effect that it can have on the L5 specifically, because obviously like
I was going to bring that up.
The weight-bearing portions of your spine are mainly C7 and L5. C7 carries the majority of the weight of your head and your cervical region, and then L5 carries almost all of the weight for everything else, including that cervical region. And that's because that's where you're transitioning from a secondary curve, so a developed curve, the lower dotted curve, into a primary curve. So like this primary curves are the kyphotic curves of the thoracic spine and the sacrum, and then the secondary curves or the lower dotted curves of the cervical spine and the lumbar spine. And the way that they're that they're functioning in a perfectly healthy person is that the weight is split basically 50-50 in between the disc and the facets. right? If there was to be a dysfunction of the SI joint, which would then cause a lack of lordosis or a hypolordosis, it's going to cause the discs to start carrying all of the weight, and they're not prepared to do so. And since L5,
it would transfer the weight onto the facets, correct?
no, hyperlordosis.
Okay.
Yeah,
I'm sorry.
hypolordosis transfers the
Hyperlordosis.
weights into a loss of the lordotic curve transfers the weights into the discs, and then a increase in the curve transfers the weights to the facets. So it's very important to be able to assess and keep this area functioning properly, because the SI joint has a huge impact on the curve of the spine, and and that's kind of what we were talking about with anterior pelvic tilt, posterior pelvic tilt. So it's it's very important to be able to assess it, because that L5 is getting hammered all the time, and so that's where a lot of the low back pain, sciatica, like discogenic pain comes from, and it could have started at dysfunction of the SI joint.
And let's say you have an injury, like if you're carrying someone up the stairs and you fall back on your tailbone and you irritate the structures and the muscle structures and the ligaments that are attached to the SI joint. The lack of movement in the SI joint, like Eddie was saying, could cause the change in axial weight bearing in the inferior or the more inferior portions of the spine, like L5, like L4. When we talk about disc herniations in young people, the longer that you have dysfunction in the SI joint, increases your chances in the future of potentially getting something like a disc herniation, lumbar back pain, something that has to do with sciatica. And again, there's no real way to predict what kind of dysfunction you're going to have in the lumbar spine as a result of SI joint dysfunction, but you also have to think about all the other anatomy in that area as well. You have the erector spinae tendon, the thoracolumbar fascia, that are going to squeeze in the inferior portion of the spine where the sacrum and the ilium meet the lumbar spine. You have the iliolumbar ligament, so any kind of slight rotation that you have in the lumbar spine or the ilium can directly affect the structures of the opposite joint, or what I was just saying. And we may get clipped here and say, I don't really think anybody's going to clip us, but if we do get clipped here, like, anterior pelvic tilt is a lie. I'm not on the wave of people saying that postural changes aren't real. I get it. Posture is a result of how our muscles are relaxing and contracting while we are weight bearing, and it's subconscious. People say, oh, well, chiropractic is just trying to improve your posture, and that doesn't exist. Yeah, like, we're not just going to necessarily bang the posture back into your spine, right? We talk about all the time about an x-ray being a picture, it's a static picture of something that's always moving, even though I do find some value in x-ray.
Mm-hmm.
I think it's hard to disprove that x-ray isn't usable at all, but at the end of the day, you do have to take into account what's going on with all those other structures. So is anterior pelvic tilt real? PubMed seems to think so, NIH seems to think so, but just not necessarily in the way that it's talked about on social media a lot. So we just have to remember that when we're explaining it. No, we're not saying like it's a major problem, but will it contribute to the way that axial weight bearing is impacting with gravity on the lumbar spine that could lead to degenerative changes 10, 20, 30 years in the future? Absolutely.
For sure.
Thing that Eddie kind of mentioned early on was the time of like fusion for like the innominate bone. So, early childhood, the SI joint is like very like mobile. It's highly mobile. The surfaces themselves are actually a little bit smoother, so it allows it to be more mobile. But then you think about when people start to have, that low back pain, and it's usually like there are some cases younger, but most cases are when people start to get into their 20s and 30s.
Mm-hmm.
And around that same time is when the surfaces start to become more irregular. So that decreases mobility already. And I know we talk about with motion palpation, the body wants mobility. When it has decreased mobility, that's when you start to see some problems arise. But then you go even further, 40 to 50 years of age, when really low back pain starts to become an issue, the joint space is starting to get smaller. The mobility is then further reduced. So that right there is going to be causing pain, because you got to think about the proprioception and like neurology of that area. Like the SI joint and its surrounding structures are like highly innervated by nociceptors and mechanoreceptors. So when you are having decreased mobility and in that kind of an area that is that innervated, that's going to explain why the SI dysfunction can cause so much pain. It changes your movement, so you have altered movement. And then what Joe was touching on earlier, your body starts to compensate for all of that. But
Can I build up the nociceptive thing once you're done?
no, yeah, I was just about to pass it back on.
And I guess I was going to talk about the literature efficacy when comparing manipulation and adjusting in chiropractic to other kinds of modalities like surgery. But I guess we could talk about this first because that's a good segue off of what Gabe was saying. People say, like, are we putting the SI joint back into place? Are we moving the alignment in a way on the sacrum that it's sticking there and we're improving the function by that? No, that's not really existent in the literature anywhere, wherever you look. But the possible changes that are going on when we go all the way back into the 90s and the early 2000s when some of the initial research was going on, one of the main theories of why chiropractic works, and I want to say it's a little bit more than a theory, because Heidi Havoc, along with a lot of other researchers over the last 30 years, MDs, DOs, PhDs alike, not even necessarily just chiropractic researchers, talk about the role that nociceptors and mechanoreceptors play when it comes to eliminating pain and allowing the body to move through a pain-free range of motion, at least for a time, to allow them to recover, right? A part of what we do, or a major part of what we do in chiropractic, is to adjust someone, eliminate the pain in the area, at least for a small amount of time, condition the ligaments and everything that are in that area, and then that movement that the person is now participating in is going to allow the body to heal better. And obviously that's just one of the mechanisms of it, but there's a 2002 study, and I like to try and quote research within 5 to 10 years, study from 2010 on possible nociceptive structures in sacroiliac cartilage, an immunohistochemical study by Carolina Sidak, and then I guess Piet Hoogland. This is from 2010. And then there's an earlier one from 2002, a continuation of studies from the 70s and the 80s. But what they found is the most nociceptors that they found and mechanoreceptors when relating to the anatomy of the hip were found in the deep ligaments that we had talked about earlier.
Yep. Sacrotuberous.
Sacrospinous, as well as
Sacroiliac?
Well, sacroiliac, there's another kind of structure that was down there. But what we're doing when we go in and we adjust and we thrust in the area of the restriction that is had on the sacroiliac joint, you condition these ligaments that can't necessarily be affected by exercise. So exercise is great. Passive and active modalities are great whenever you're dealing with an SI joint issue, but that's not necessarily dealing with the deep nociceptive pain that is going on at the bottom histochemical or histological level of the SI joint. So you have these two things called CGNRP and substance P. Those are two really big topics of conversation right now in the chiropractic world. And what's happening is the sensation from the CGNRP and the substance P released from the area that is injured are competing with reflex loops going into the spine and sending signal up to the brain. So when we adjust and alter the release of the CGNRP and the substance P by activating a separate reflex loop for sensation going into the spinal cord, that is how we can allow the brain, by activating proprioceptors and mechanoreceptors, to then allow the body to move through that range of motion to say that it's safe and then decrease pain at the level of the joint. So we have that evidence there. We can even quote some of that for you guys, or we'll put it in the topic notes, right? But then the more important area of conversation is what we're doing. Is it supported by research? Is there room in the literature between chiros and physios and osteopaths that we can say that this is a legit way to take care of somebody with SI joint dysfunction? So as you were saying, still a decent percentage of the population is dealing with lumbar back pain that is really SI joint pain. And just a quick side note, something that they tell us in differential diagnosis, if somebody comes in with low back pain, shoulder pain, wherever it may be, have them point to the pain. Because half the time they say, all right, I had pain in my low back, and really they're pointing to their hip. And then now we know we're dealing with an SI joint issue. One study that popped out for me in particular was efficacy of manual therapy for sacroiliac joint pain syndrome, a systematic review and meta-analysis of randomized control trials. This, along with other trials that looked at, combined this one in particular, 16 RCTs, 11 RCTs being analyzed with the meta-analysis, came to find either that spinal manipulative therapy and adjusting had an equal effect as exercise, or elevated when combined with the exercise. So what we were saying, you can strengthen the muscles in that area, you can try and relax them, whatever that means in the literature. I know some people are like, oh, can you even relax muscles with stuff like MRT, which I think we can, but I guess you got to get down to the nitty gritty with that. But when combining this gapping force in the plane line, so like a 45-degree plane line of the ilium, we can compete with the nociceptive stimulus going to the brain, activate proprioceptors, and then allow the body to move through that pain-free range of motion, because we know movement is what is then going to heal, right? Compete with the stimulus that's going on at the microscopic level of the muscle and the deep ligaments, and then do your other passive and active therapies on top of that.
Agreed. Well, I mean, is there any other literature that you would want to go over? Or do we want to get into how it is that we assess the SI joint? Because I think we've established just how important it is to be able to assess issues at the SI joint, and unfortunately or fortunately, it is one of the harder parts of the body to assess. Right? We have a lot of different orthos, we have a lot of different palpation techniques, we have a lot of different special tests that we use, but it's...
if you will finish it now, there's one other thing I want to talk about with that.
No, I'm just saying that we should get into the assessment because it's very important that that as chiropractors, especially if you're early on into your student career, you start getting comfortable and start getting the reps in on how to evaluate the SI joint.
Yes. And just a couple others, and I think we don't even need to necessarily go over all of them, but we can link them for you guys, and I think I want to make an Instagram post just with all the research that we had so it's easily accessible. But we have to compare what we're doing with active and passive modalities with the more common treatment methods like injection, like spinal SI joint fusion. A lot of the issues, and I think what are going to be more pronounced in the literature as we move forward, but what's been pretty stagnant in the literature for the last 20 to 30 years is the debated motion of the SI joint, like we said, but then not necessarily incorporating how the SI joint is moving, how that could be affecting nociceptive stimulus, going to the brain, stimulating mechanoreceptors, and how that could be possibly attributing to the person's pain. When we do an SI joint fusion and then we eliminate that motion altogether, if the pain was from a lack of movement, which is what happens when there's swelling to the area, that can also affect like posterior sacral nerves, all that kind of stuff. That could impact the body drastically. So when we're fusing that joint, now we have to have hypermobility compensation of the joints above, which then becomes a whole nother issue. So I think it's more than worth it to try adjusting the SI joint. We have evidence for it. Maybe trying some other passive active therapies, whether it's through a personal trainer or a physiotherapist or a PT, or maybe your chiro does that as well, to try and get you out of that acute inflammation stage and away from surgery. I mean, we could talk about Carson's dad, my dad, Gabe's brother, our professors, adjusting people who are on the brink of having surgery and being brought away from that brink and then allowing them to move and actually do some rehab because they adjusted the SI joint and allowed it to move through that range of motion. So there's a couple things that I want to go over real quick. So one of the things that's really pronounced in the literature, that how osteos and MDs, orthos, talk about how do we know there's dysfunction at the SI joint. There's a group, typically it's about grouping 2, 3, 4 tests that are positive that can then tell you that there's SI joint dysfunction. Carson's going to go over some of those that are kind of built into our gen scan, so we can actually have data and information on how we evaluate the SI joint that's then accepted across the literature. But a couple of the more popular ones are just going to be fib-airs. So we're going to lift up the foot, we're going to place it on top of the knee, we're going to grab the opposite iliac crest, and then we're going to just pressure down with the knee. We're looking for pain or tightness there. Obviously, Carson would say, that is positive for coxa pathology.
Yep.
I think it's called coxa pathology.
Which is just...
That just means hip pathology.
Yeah, hip pathology. Yeah. Some of our professors don't know that.
Bring the knee up. We can take one hand on top, grip under the bottom, press down. That's going to be the Feder's impingement test. So if that's positive for sacroiliac joint dysfunction, hip impingement. Carson, go ahead and roll and face the camera. So this is all stuff that we learned in neuromuscular diagnosis. So NMS2, I think, was the class that was for lower extremity.
Yes.
If we go and we press on the hip sideline, so we would straighten his legs, just press down on the hip. So this would be a sacral thrust or a hip thrust test. Also positive for sacral pathology.
That's iliac.
Or iliac.
Iliac compression.
Iliac compression. Iliac compression.
I think the last one was thigh thrust.
Or the last one was thigh thrust. Sorry. Thrust there, and then go back down on your back there for me, Carson. And then this would be iliac distraction, correct?
Yes.
Hand on both ASIS. And we're just going to distract outward. So those are just some positive tests that we can do. A lot of chiros, or not a lot of chiros, but more chiros need to utilize things like VAS, visual analog scale, pain scales, oswestry, disability index. So we can have the patient fill out something for their pain that's accepted in the literature, and then after we adjust them, or manipulate, or whatever you call it, as well as doing all your different kinds of active passive modalities, is there a measurable improvement in the pain and quality of life? And I think there was one study in particular that we can also link. This is one that I really wanted to talk about, but they compared the quality of life. It was a quality of life index between spinal manipulative therapy as well as, or they compared it to exercise. Both were equal in how they improved the pain levels of the patient, but only one was superior to improving the quality of life index in the patient after adjustments. And I think it was 5 adjustment sessions for lumbar pain and sacroiliac pain. But so for improving pain, both were pretty similar, but for improving quality of life, the adjustment took the cake in that one particular study. But Carson's going to come up and he's going to show how we analyze the sacroiliac joint as a whole.
Okay guys, so I'm going to be going over the analysis of the sacroiliac joint. In doing this, I'm going to show you the palpation side of things. CJ showed you some orthos. I'm going to show you how, as a chiropractor, we can palpate the sacroiliac joint for some of the various motions that we were talking about. And so briefly, just to cover what we're feeling, we have in our joints in our body, we have 3 different types of movement. We have active movement, and that's the movement that you do on your own where you engage your muscles to move a joint. We have passive movement, which can be done by somebody else, where they can take your joint and take it through a range of motion, somewhat similar to what you would do in stretching, where you pull a joint into an extended range of motion so you can stretch your muscles. That's done by somebody else, but we also have a third type of motion that we can assess in our synovial joints, which is called joint play. Brief history, Dr. John Manel is credited for our modern understanding of what joint play is. And joint play is just small movements within a synovial joint that test really the integrity of the joint. Is the joint moving in fluidity as it should, or are there these hard restrictions that are causing the joint to have some sort of malfunction in the way that they're moving? So to get into the palpation aspect, we have several different positions that we can palpate the patient in, and I will show you various ways to do this. But to start out, we have our patient, which would be CJ right now, is going to be in this seated position on the end of the table. One thing that I want to make sure that we cover is that we really want our patient set up to be proper so that we can feel the correct things. I can't have CJ's legs spread out wide on the table or him leaning to one side or the other. I want CJ's feet in front of the table, right in front of him, so that I can assess the SI joints properly. And I want him in a nice neutral posture. I may have him bend into different postures, but to start out, I want him just in a nice neutral posture, relaxed with his feet in front of him. So to start out, we're gonna assess the left SI joint. So in doing so, I'm gonna take this position where I scoop my butt to the side of the table. I'm gonna take one hand and I'm gonna place it right over the back of CJ on top of his shoulders. In doing this, if I need to pull CJ into flexion or extension, I can easily do so using my entire arm. He feels safe and my arm is in control, and I feel safe and stable on here, as opposed to trying to do it with one hand, which can be unstable and throw off his posture. So big strong hand on the shoulders. The first thing that I'm going to palpate for is the ilium moving into extension. And so this is where we can get into, there may be some differences in the way that people talk about how the joints move. The way that I'm going to describe it is, as Eddie talked about earlier, the words nutation and counter nutation. I typically like to refer to that as the way that the sacrum moves back and forth. So we like to describe just the very, very basic terms so people can understand it easily, as the sacrum is like a pizza-shaped bone. So I can take my hands and just make them into a triangle like this. The top part is the base, and the bottom part is the apex of the sacrum. Now when the base rocks forward, moving this way, that's nutation of the sacrum. And when the base rocks backwards and the apex moves forwards, that would be counter nutation of the sacrum. Now you can see if CJ is in this neutral position, if I push him into extension, his sacrum is going to rock forward like this. That would be nutation. And if he came back into this flexed posture, you can see how his hips kind of rotate back like this. That base would be coming backwards, and that would be counter nutation of the sacrum. Now, when I'm referring to the ilium and the movement of the ilium for demonstration purposes, I'm going to say flexion and extension. Now, extension of the ilium is when CJ moves into this extended back posture. That would be the ilium rocking forward. We call that extension. When I have the ilium rocking backwards, as when his leg would be coming up. A better way to demonstrate it would be like this. You can see my hips. If I have my hip coming way up like this would be my ilium moving into flexion. If I had my leg coming back like this would be my ilium moving into extension. So I'll demonstrate that and talk about that as I'm doing these palpations, but let's get into the palpation. So first thing, we talked about our stabilization hand. There's a couple different ways we can palpate with this opposite hand. I'm gonna show you an open grip contact, and I'm also gonna show you a fist contact. It's really doctor preference in doing so. We wanna make sure that we're not, super jabby and using these really bony, pushes right into the patient's spine. We don't wanna make them feel uncomfortable. So the first contact is I'm gonna use this thumb pad right here. We call it our thenar pad. I'm gonna put it right over the PSIS on his left ilium. In doing so, I'm gonna feed into this joint because I wanna be able to take the slack out of the joint, and then I wanna feed in a little bit more. So I'm feeding into the joint, and then I'm feeding in a little bit more, and I'm checking for the joint play in that left SI joint by contacting the ilium. So I'm right here and I'm feeding in, and then I'm giving it a little bit more. And I wanna feel for a nice springy wiggle. Proper joint play will feel like an elastic or a springy little small movement like this. A joint that does not have its proper joint play or that is restricted is gonna feel very hard and stiff, and you're gonna try to move a joint like this, and it won't be moving and gliding off each other. It'll be really stiff, and both the ilium and sacrum will feel like they're really forcing movement together instead of gliding off each other like they should. So with all that being described, I'm gonna take the stabilization hand, I'm gonna go on to the PSIS, I'm gonna feed in and then a little bit more, and I'm assessing for that fluid motion. I'll flip over and do the same thing on the other side. I'm putting my stabilization hand here, and I've got hand on the PSIS, feed in, and then a little bit more, and I'm feeling for the joint play. Now, you can go about assessing this pelvis very different ways, but one way that's really easy to do it is when we're assessing for that extension of the ilium, we can put the hand just like we did, feel there, and now we can slide down to the bottom part, which would be the PIIS. That would be that second part of your sacroiliac joint where we can assess for flexion of the ilium. So it's a little difficult to use an open palm contact all the way down here. I would prefer to use a fist just like this, a real soft fist, and instead of being right on the PSIS, I could come down to the bottom part of that SI joint and feel more down towards the table. That way I can rock it back like this. I can rock the ilium back, and I can feel for that opposite motion. Instead of rocking forward, I'm rocking back now. That can be done really quickly together, so we can feel for the extension, then we can go right in and feel for the flexion of the ilium. I can do the same thing on the other side. Right here, I'm feeling for the flexion, move my hand down, I'm feeling for, I'm feeling for the extension, I'm moving my hand down, I'm feeling for the flexion. That's how we would assess the ilium's movement on the sacrum. Now for the sacrum's movement on the ilium, I can take this, we like to call it a raptor claw, but it's our stabilization hand. It's just the same way we did it before. And now we're gonna take a soft fist, and for this motion, I can assess CJ in the neutral spine position where I'm feeling just general joint play. But to get a real end feel for this sacrum, what I wanna do is I wanna push CJ's back into extension. I wanna get him really extended so we can feel the end range of that joint play in the sacrum. With this, I'm gonna take a soft fist right on the base of the sacrum. So if we're going back to our pizza, that's the top part. And I wanna feel for this motion where the sacrum's rocking forward on the ilium. So I'd put my fist right in here and I'd feed in, and then I'd give it a little bounce. And I'm feeling, does it have a nice elastic bounce? On the contrary, I can pull CJ into a flexed position, and now the base is gonna be rocking back, the apex is rocking forward, and I can check for counter nutation of the sacrum. To do this, we can either take a soft fist and go down towards the table, or we can flip our hand over and use more of this curved surface on our hand right here, and we can put it into the same angle that the sacrum's moving downwards. We want our hand to be able to assess with that same direction, so I can put it down towards the table and I can assess for that motion of the sacrum moving this way on the ilium. So that's the way that we assess it from our general scan position, and our general scan is a way where we can just palpate the spine very quickly, looking for areas of hypomobility, so areas where they're not moving well, versus areas of hypermobility where there may be too much movement. And in doing so, we could quickly assess the whole spine, moving up through the back. We could check some things in the cervical spine, but for the sake of time, we're assessing the pelvis. So I'll have CJ lay flat onto his back. This is another way that we can. It's another way that we can assess the SI joints. This is a supine position, and so I'll show you for two different options to do this. I'm going to take CJ's leg and I'm going to move it up into this 90-degree position. Now this is going to look very similar to the ortho that CJ showed, which is the thigh thrust, where you're thrusting down this way. Instead of using it as an ortho, we're going to use it as a palpation for the SI joint. Now, depending on the size of your patient and the length of their femur and the size of your body and length of your arms, you may want to do this with the patient's opposite leg or the same side leg. But what we can do is we can take a hand and we can place it on the back part of their hips on the SI joint. We want our hands to be right around that PSIS so we can feel the ilium and the sacrum gliding past each other like this. To do that, I place that hand on the PSIS. I have the other hand right here on the top of CJ's knee. I'm going to place my chest right on top of the knee. And so I'm going to feed my chest down, or I'm going to feed this motion down in towards the table. The first little bit of motion that I'm going to feel is the femur moving into the acetabulum. So that'll be that like femoroacetabular joint motion. And then once I get all that motion out, then I'll be able to really assess for the joint play of the sacroiliac joint.
I feel some dysfunction back there. I'm not
Do
gonna
you?
lie.
Yeah, so yeah,
I feel some dysfunction.
already feels it.
CJ needs an adjustment.
So we got our hand on the SI joint. I'm feeding in a little bit, and now I'm feeding a little bit
clinic.
more, and I'm just gliding that femur down through that joint. And what I will feel is I will either feel the ilium and the sacrum rocking back and forth as I put motion into this joint, or it'll feel like those two structures are moving together and they're not gliding past each other. Moving together would indicate to me that he does not have proper joint play, so he has a hypomobility in that area, and we may need to adjust that. I can do this with the same side. Could be a little bit easier, so I would take the leg like this, I'd roll it over, I'd take my hand and I'd put it on the SI joint. Same thing, I can put my chest right over the knee. I'm feeding in and I'm getting that hip joint motion out, and now I'm gonna feed in a little bit further and I'll be able to feel the SI joint rocking back and forth, the ilium and the sacrum rocking back and forth like this.
Sorry, Carson. Eddie, can you go just open the dryer's door so we stop that beeping? Thank you.
Should I keep going now?
Yeah, keep going.
Okay. Now I'm gonna have CJ roll onto his side. We have a sideline palpation that we can do. So I'll show you this way. The sideline palpation we would do on both sides of the table. So right now I would be assessing his left SI joint, but after I do that, I would flip him over and I would assess his right SI joint, but that blocks the camera, so I'm not gonna do that. We wanna take one leg and straighten it on the bottom. This will allow the pelvis to be very neutral. And then we'll change the angle of the pelvis with this top leg. So the first palpation that we can do is we can bring the patient's leg up, have their ankle joint kind of right in the back of their popliteal fossa. It can just rest right in there. And now I have a couple different things I can do here. To start out, I can place my hand right over CJ's PSIS, or his sacroiliac joint right here, but the PSIS is the structure that we're looking for where we can find a good contact point to assess the joint. First, I can take my hand on top of his knee, and all I can do is I can just push the knee downwards, and by pushing the knee down, just like this, I can feel the ilium gapping off of the sacrum a little bit, or I should feel that. If the joint is not functioning properly, you won't feel any gapping and it'll move together. But I can push down and feel for some gapping in the SI joint. The other option I have is to shear the femur back through the femoroacetabular joint, and in turn I'll be able to glide the ilium off the sacrum. To do that, there's a couple different ways I can do it. I can either take a hand and just place my knee right on top of my hand, and I can shear the joint this way. So I'm I'm using my leg to push this way, and I'm trying to shear this joint right here to where I can feel the ilium shearing off the sacrum. If I feel this motion where they're shearing off each other, that's good joint play. So I can do this. I can also take a double hand contact where I put his knee in between my knees right here, and I can move my knees together in this direction, cover his SI joint right here, and feel as I shear his knee in this direction and feel for that joint play of that SI joint. I would have CJ flip the other direction and do the opposite SI joint, but I'll show you the final palpations here. From this position right here, we're not going to be so focused on the ilium moving on the sacrum. We're more so going to focus on the joint movement of the sacrum. So in this position, I'm going to come to the head of the table up this direction. And since CJ has a more neutral spine right here, this is going to be the best way for me to palpate the counter nutation of the sacrum as opposed to the nutation. So this is counter nutation of the sacrum. I'm going to take my hand right around my thenar hypothenar area right here, and I'm going to place it right onto the sacrum. You can look for kind of the S2 tubercle area and place your hand right here. What we don't want to do is we don't want to have our fingers grabbing down and having our whole hand like this. That's uncomfortable for the patient and not professional from the doctor. So make sure that we have our fingers kind of spread up this way, and we have our palm right over that sacrum area. I'm gonna back my other hand up right on top of it. I can either go sideways or I can make a fist and go right here. But what I'm gonna feel is for that joint movement of the sacrum to move like this. And so I'm gonna get really low like this from the head of the table, kind of in a lunge stance right here. And I'm gonna make sure my fingers are up, and I'm gonna feel that sacrum moving in that counter nutation motion. I should feel in between where the L5 meets the sacrum, I should feel a little bit of gapping in this part of my hand right here, where the L5 and the sacrum is moving off the L5 this way. I should feel a little bit of movement there. On the contrary, I can palpate for nutation, and to do so, I'll have CJ come up onto his elbows. And when you see this, it kind of changes the angle of his pelvis. He gets more of that nutated motion where his pelvis is moving from neutral to nutation because we bring his back into a more hyperextended state, which will have the sacrum rocking forward a little bit. To do this, I'm going to take same part, thenar, hypothenar type of placement on the sacrum. I'm looking for the base of that sacrum, so the top part to be rocking forward, so the nutation of the sacrum. I'll place my hand right on top of it, and I'm just going to take a straight arm, and I'm going to feed right down into the sacrum, and I'm looking for that springy or bouncy feel of the sacrum moving forward. Now, this would be a good point to ask your patient when you're palpating if the movement of the sacrum, nutating forward, if this is what you're palpating for, does this bring relief or does this cause more pain and pressure?
It causes more pain and pressure.
And oftentimes, as CJ just said, the patient will say if they're already, spending a lot of time in that hyperextended state, that this will cause a lot of pain and pressure. So we don't want to give, too much pressure and motion into it, as it will be uncomfortable for the patient. But do be conscious and aware to do check-in with your patient. Ask them if the palpations that you're doing are causing maybe some relief of symptoms or whether they're causing further pain or pressure into the joint. And so in review, CJ, I'll have you come back up to the seated position one more time, and I'll just briefly talk through what we went over. We have the general scan position where we can assess the sacroiliac joint, contact the ilium, extension, flexion. Then we can do the sacrum. We'll have CJ go into that extended position, nutation, flex forward, and we have counter nutation. We would do the same thing on the other side, extension and flexion of the ilium on the sacrum. We could also palpate with our other hand if we wanted to, the nutation and counter nutation of the sacrum. And then obviously we have our side posture, our prone palpations, and our supine palpations. So make sure that you are aware that palpation is a skill that has to be developed. You're not going to sit down and feel all the motions of the palpations perfectly and know how to treat any and every joint dysfunction through palpation the first time you sit down. It is a psychomotor skill that you have to practice with repetition over and over again, like you would hit a baseball and like you would shoot a basketball. So if palpation is hard, don't give up your first time in doing it. Spend the time getting good with your hands, because chiropractors have to be good with their hands.
Awesome.
Nice. All right, guys. So we're going to go ahead and show you guys some of our adjustments and how we adjust. But we want to preface this with we are students still. We will not be doing any adjustments. We are just showing the setups. I want to make sure that is said clearly because We are not allowed to adjust off campus, and if anybody watches this and sees what we're doing, please practice the setups, but do not adjust. Like I said, we are just students. We are not doctors yet. So I just wanted to preface what we were about to show you with that, just to ensure that you guys know that, one, we are not adjusting here on this podcast. You will never see us send an adjustment on this podcast. We just want to show you guys how we like to set up adjustments and kind of like how we get into them. So just palpating and the setups are all you will find here. And I cannot state it enough, please do not adjust off campus.
Make sure before you ever work with the patient that you get their permission. Some of the positions that we put them in are a little bit vulnerable, and our goal as a practitioner, as someone who is trying to figure out how to help you, our goal is to recreate pain. So make sure you're always asking permission, make sure you're always finding ways to make your patients more comfortable, and make sure you have other ways that you can use to alternate what you're doing in case a patient does feel uncomfortable in that position.
So the first thing that we're going to get into is going to be a side posture push. Now, really quickly, I want to talk about the technique that I'm going to be going over. This is technically called Palmer package or Palmer Gonstead, but this is the posology. This is for the students that are just now getting into adjusting. This is the way that by the book you're supposed to do it. And we teach it this way because schools, specifically Palmer, have to teach thousands of students how to do something. And this is kind of like watered down and made so that everybody can understand it. Now, with that being said, we're all going to show our different variations to the adjustment because everybody's anatomy is different, every patient's anatomy is different, and you have to adapt. But this is the way that like the school teaches you to do it, and I'm also going to be going over a couple of things that we make sure that we don't do, because there's a lot more yes do's than there are don't do's, but the don't do's are very important to know. So the first thing I want to talk about is going to be patient placement. With a side posture adjustment, obviously the patient's going to be on their side, right? And there's a way that we call it perfect patient placement, and you instruct your patient, all right, this is what I want you to do. I want you to sit down on the table, right? Reach your arm out, and this isn't going to be for when you're adjusting students or healthy populations. This is for when you're adjusting people that are a little bit more progressed in age, and they need to be instructed on how to get it in a painless way. So it's going to be, please sit down on the table like this, take one arm out, guide the other, and slowly guide yourself down to when you can lay your head nice and calm on the pillow with the headrest elevated if your table has a headrest that elevates. And then from there, the patient's going to be with their leg up like this. This is the angle that I'm using to show you guys. This is what the perfect patient placement looks like. This is a side posture adjustment patient placement. Now, with that being said, CJ facing me, can you assume the perfect patient position? Now, I'm going to be talking about a side posture push for a posterior inferior ilium. Without getting too into technicalities, this is an ilium that has technically rocked backwards and doesn't want to come up. So what do I want to do? I want to give it that motion of coming up. So placing the spine on CJ's side, right? The goal with this adjustment is going to be to place my pisiform, right? That fleshy pisiform underneath the PSIS so that I can then apply an impulse which is going to force the joint upwards, allowing that patient to have proper motion in that area. The first step, sorry for getting on your toe there. The first step that we want to look at is making sure that the patient is correctly positioned, because this is what's going to give you a lot of your tension and it's going to make or break your adjustment. We want this bottom leg completely straightened out, the ankle on the crook of their knee, and then from there you want the patient's spine to be neutral. I could go and ramble for 30 minutes about spinal cord dynamics and why it's incredibly important to keep a neutral spine, but for the sake of the teaching, we're gonna keep that short. And then on this adjustment, my weight is going to come on the lower part of the leg. I'm going to stabilize with my leg on the lower part of the leg, because if I stabilize all the way up here, I'm locking that SI joint into place. But what I want to do is use that lower leg as kind of like a fulcrum to open up that SI joint. And you can feel that when you place your hand on the SI joint, if you push the lower leg down, you can feel that SI starting to open up. So then from there, I'm going to stabilize on the patient's shoulder with my non-contacting hand. I'm in a scissored stance, right?
I'm going to tissue pull, so I'm going to
that real quick.
I'm going to pull with my hand, guiding up the SI joint. So here I can push and feel that joint play that Carson was talking about. I don't want to do the small local tissue pull and then stab them with my piezoform. That can be uncomfortable. I'm going to take a hand and guide it up, starting to preload that motion that I want to introduce into the joint. From there, I'm going to roll the patient into me so that I'm not bringing myself over them, putting us both into an uncomfortable position. I'm going to get my tissue pull, roll the patient into me, and from there, I stabilize up, creating all the traction that I can throughout this musculature, and I have my hand on the PSIS coming through, and I can still feel that joint play in there. And then I want to take the joint to tension, and then from there, it's a pec tricep push into the table, right? We have stabilized the patient up, tractioning that spine. I have all the tension here. My weight is on the lower part of it. Most of my weight's actually here on that front foot. This leg is just there to stabilize. And then from there, it's a little bit of a body drop and pec tricep push, moving the hand 45 degrees across the SI joint where it moves, right? That's the way that it's taught by the book, right? For my anatomy and for what I think is most efficient, I use a couple of differences, and then it's just, one, I'm a little bit more squared away to the table so that I can feel like I'm more athletic and I have more control of this knee here. I use the same tissue pull that I talked about just then, but instead of stabilizing up at the shoulder, what I will do is stabilize here at the hand, and I will bring my body closer to the patient so I can be here, and whenever I deliver the thrust, I can come straight down, allowing the force to go straight through the SI joint, right? And I do that because it saves my shoulder a little bit, and I feel like it's a little bit more comfortable for the patient instead of me being completely tractioning them out and being too stiff. So I'm here, and then from there, the body drop, pec tricep push is just a little bit more into it like that. So that's my variation of doing a side posture push.
Alright guys, so I'm going to be going over what Carson and I kind of lean more towards, the motion palpation, side posture, kick / drop. For this one, there's not too many differences of what Eddie just showed you guys. I'm just going to go ahead and just run through it. We'll set up, same as what Eddie was saying. I want to pull and make sure that his leg is straight, really emphasize on keeping that leg straight. Before you do that, you always want to make sure that you ask your patient if they have any knee, ankle, or hip issues. Obviously, I do not want to yank on their ankle and pull down if they are having any of those issues because it could cause more pain. I'm going to make sure that that foot is tucked behind the opposite leg's knee. And for this one, I'm going to go ahead and demonstrate a kick. So the difference between a kick and a drop is when I'm doing a kick, I want my patient to be a little bit closer to the edge of the table. So I can cue Carson just to scoot up a little bit. This is important because I do not want to set up on him on this kick. And when I'm going to kick down on his leg, I do not want to kick his leg into the table. Some tables can have like little dials, as you guys can see on this side. And if you kick your patient's leg into that, it's going to hurt quite a bit, and you don't want to hurt your patient. So once I have my patient positioned where I have him close to the edge of the table, I then want to cue him to tuck his lower hip closer to me. This is going to bring his leg up at 90 or above. Again, this is kind of going along with the last point. I want this leg to be 90 or above because when I'm setting up my kick, I want it to be able to go as far as I can without hitting the table while also building in that compressive step. So once he's here, this is my patient position. This is where I want him. So next, I want to get my left leg when I'm on this side, and I want to put it up against the table. I do this because if I stand away from the table and go to set up, mount up for this kick, I'm not going to be stable. I'm going to be kind of leaning from side to side, and I'm not going to be able to keep my stability throughout the adjustment. So I'm going to put my front knee up against the table. This way I can do whatever I want, move around, and I have that stability. Once I'm here, I'm going to do what we call mounting up. To mount up, I want to bring my leg up, trying to get my knee close to where his back pocket would be, but even more important, if you guys can see, I'm locking this ankle here on his knee. This gives me full control of his leg so I can move it back and forth. From here, I'm going to find wherever was restricted, so we're going for that SI joint. And so I'm going to do what we show is a pull. So using kind of like a bird beak contact, I'm going to find that PSIS, that marble-like projection. I'm going to kind of grab onto it in that bird beak fashion. And the difference here is instead of kind of like pushing his elbow or shoulder up, I'm going to build in this compressive step where I'm going to kind of round out, doing like a snowball effect, bringing my hands lightly together as if I was making a snowball. So here, once I'm there, I can then move his leg up and find where that restricted motion is. And then from here, I would kind of apply tension, bringing my leg down, and then I would kick and pull my elbow towards my chest at the same time. The big thing here that we like to emphasize is I do not want to kick my leg back as if you were starting a motorcycle. I'm wanting to kick it just hinging at my knee as if there was a soccer ball underneath the table that I was trying to kick at you guys. So it would just be hinging at that knee, kicking what's underneath the table. And that's pretty much the basis of the motion palpation kick pull.
Alright, so I'm going to show you guys a drop. This is also like a motion palpation style side posture. Gabe kind of touched on a lot of the basics of the setup, so I'm not going to repeat a lot of that, but one thing I did want to add is that if on the palpation I found that he had an extension restriction, I'm going to make sure that this leg is in extension like this. If he had a flexion restriction, it's going to be more in the flexion like this. And so, similar to the drop, I'm going to grab, push it back into extension. Similar to the drop, I'm going to take this hand and compress it like a snowball. And this hand, or on this side, what's going on is I'm contacting his leg with my leg, and I'm putting more of my weight on him. I'm going to contact his SI joint just with my hand, my pisiform, and I'm going to roll his hip down like this. And as I'm doing that, I'm going to do like a body drop and drop my weight onto him. So I'm not going to adjust, but in real time it would look something like that. And yeah, that's pretty much it.
I just rather have you rush.
Okay, guys, so I'm now going to show you similar side posture setups that Gabe and Joe just showed you. They showed you a kick and drop. I'm going to quickly reiterate a couple things they said, but I'm going to show you how we can contact the sacrum as the primary movement in this joint, the sacrum moving on the ilium, whereas they showed you a lot of ilium contacts on the PSIS. I'm going to show how you can contact on the base of the sacrum versus a lower contact of the apex to get it moving either in counter nutation this way or in nutation this way. So for the drop, if we're going to do a drop adjustment, the setup is going to be almost identical to what what Joe just showed you. So for nutation of the sacrum, I want to facilitate the patient's setup to go into the motion that we want the joint to go into. So if I want nutation of the sacrum, I want to figure out how I can get the patient set up where his sacrum is rocked forward like this. To do so, I'm going to take the bottom leg and I'm going to keep it in that neutral position. You can see the difference between if I take CJ's leg and I move it up like this, you can see how that pizza-shaped bone is going to be moving down this way. Now if I move the leg into a straight leg or into extension, you'll be able to see the sacrum get that motion where it moves back up like this. So for that nutation adjustment, I'll take this bottom leg and I'll straighten it out either completely or I can put it into even a little bit more extension like this. This leg, same thing, the ankle's going into the back of that knee joint, that popliteal fossa, and I'm bringing the knee upwards like this. Now, like we talked about, we want the patient close to the edge of the table so that we're not, putting that leg or the knee with our adjustments into the side of that table. But since we're doing a drop, we want, instead of the angle of the hip, like Gabe talked about on a kick being upwards so that we have space to kick down, we want the knee pointing downwards. So I can cue CJ to either rock back on his hips this way, or I can just ask him, can you point your knee down off the table? Now you can see how he's extended, where he has that nutation facilitated in the sacrum, but he's also in this position where the knee's coming off the table, so I can roll him easily and not have the knee sticking way up in the air, getting in my space. Now for the drop, obviously like they talked about, we want to make sure that when we're setting all this up that they don't have any joint problems here, and we want to slightly traction out the shoulder up on the upper side, and we'll just lay it right on the body, and we'll lay the arm right on top of it. Only difference in this adjustment, instead of using either my piezoform or my hypothenar to contact right on the PSIS, which would be right here, I'm just going to slide down to the base of the sacrum. So instead of here, I'm going to go right on the base of that sacrum. And I can just take this big hand contact and place it right over the base of that sacrum just like this. All the adjustment's going to be is I'm going to roll the patient towards me, and then I am going to drop my sternum right on top of my hand. So I'll take this hand right here, I'll slightly give it a small traction down as opposed to shearing out this way. I'll give it a small traction down because I'm going to create this compressive force right here. I want to create a snowball like Gabe talked about. So I'll place my hand right over with my thenar, hypothenar, or with my piezoform if I want to take it right over that base of that sacrum. I'll go right here. All I'm going to do is I'm going to have my legs kind of in this scissored stance facing up the table. I'm going to roll CJ towards me. I don't want to go over here. That makes me very unathletic. I want to roll him towards me, and I'm going to drop right over top the sacrum with my hand feeding in this way. The other way to do that is to do a counter nutation move. So like we talked about at the beginning, I could move CJ's legs up like this. I'm facilitating more of that counter nutation of the sacrum. So we want to move the leg this way. Same thing, we're going to tuck the leg back here. Now on this adjustment, instead of doing a nutation move where we're trying to nutate the sacrum this way, we want to pull the sacrum or move the sacrum down in this direction. So there's not really a great way where I can just put my hand on it and try to pull. So what I'm going to do is more of a forearm contact, and I'm going to take my hand, I'm going to place it more up in this region through this kind of proximal part of my radius and ulna up here at my elbow joint. I'm going to take up here and I'm going to traction down. And you can see how I'm starting to create that motion where the sacrum is counter-nutating. I'm going to traction down. The only difference in this drop is when I traction down, I'm going to take the tension out of that joint, roll him towards me, and I'm going to drop, and I'm going to chicken wing slap a little bit. So this is going to be the drop for that counter-nutation. So I'll go right here and I'll traction down and I'll pull him this way, and then I'll roll him in and I'll drop, and I'm going to give a little bit of that motion where I tuck my elbow into my side. That's it.
All right, guys. To round it out here, we're going to go over an AS move. So when we talk about AS, we're referring to the ilium going into superior up the spine. But really what we're trying to refer to is a flexion fixation versus an extension fixation. So in the AS move, that means it's stuck in it's stuck in flexion, a flexion fixation. So we're going to try and offer an extension to the ilium on the sacrum. So again, perfect patient placement. First, I'm going to show you what a Palmer-Gonstead move would be. So we want to make sure that this bottom leg is back into extension, traction out, and we want to make sure that we have full stability or full control of the patient on the table. I'm going to pre-roll the patient into me. Normally it would be a skin-on-skin contact, but I'm just going to show you over top of the clothes. We're going to go from the PSIS to the ischial spine. If it's technically gone anterior or it's gone into flexion, I'm going to try and bring it back down more posterior. So what that would look like is that would be more in here on the ischial spine, and then whether it's gone IN or EX, which are two of the listing terms that we use here at Palmer, if it's IN, it's gone up the articulation, we want to bring that back down, and then if it's gone EX, it's gone off the articulation, we want to bring that back up on the ischial spine. So I'm going to take it, I'm going to do traction up on the shoulder while still remaining light. I'm going to step up the table and be a little bit higher on the patient so that I can thrust down and offer an extension into the flexion fixation on this way with more of a straight arm drop. The other way to do it with a body drop, which is not necessarily Palmer package way, but more so associated with motion palpation and other off-campus clubs, is you can traction up on the shoulder or down in with the elbow here, but again, we want to be on the ischial spine. the more you start to analyze patients, the more you start to palpate, look at skin patterns, fascia patterns, everything. If you see the constriction of the fascia starting to move down the spine into this area, that means we're in more of a flexion fixation of the ilium, and we want to try and offer an extension. So we want to try and pull down and traction the tissue, and then bring that ilium to tension right there. And then as we go, we're going to set up the patient for a drop. We want to make sure our sternum is set up over the area that we're going to drop on. So I would roll in, creating that tension with the tissue pull, and then drop my body on top. Alright guys, we got into a lot during that video. We showed you some of the research around adjusting the SI joint. We went over the anatomy, kind of gave you a little update about what's going on in our lives with the clinic, and then we showed you all those setups. So we hope you liked it. If you did like, comment, and subscribe on the YouTube video. Follow us on Instagram at The Adjusted Perspective. That's The Adjusted Perspective. This has been Carson, Eddie, Joe, CJ, and Gabe. If you want to see anything, let us know. We want to talk with you. We want to interact with you guys, but just let us know. But this has been The Adjusted Perspective with our 3rd episode. Signing off. Peace. Peace. Good job. Okay. 2 claps here. One
clap. Just do one clap.
Okay. 1, 2. Let me hear. Let me just have one person do it.
Oh,
Real quick.
sorry.
No, that's fine. This will be the last
My
one.
bad.